Hello everyone. Welcome to my November lunchtime chat with Sandy. The topic for today is the highlights and hope from the World Parkinson Congress. Before I share with you some of the things that I learned at the World Parkinson Congress that took place in Portland, Oregon a few weeks ago, I want to take a few minutes to explain what a World Parkinson Congress is, so that those of you who have not had the opportunity to attend one in the past will have a better idea of how important these events are and why I get so excited about them. These congresses have been held in different parts of the world every 3 years since 2006 and are the only global conferences that bring together the entire Parkinson community, including the dedicated researchers and health professionals who study Parkinson's and care for those who live with it, alongside the people and care partners who live with Parkinson's day in and day out. That would be the real experts, just like you. So there were 4,500 attendees from 67 countries in attendance. 27% were people with Parkinson's, 20% were care partners, 40% were neuroscientists, clinicians, researchers, nurses, other allied health professionals. The main objective of these meetings is to build a stronger, more cohesive Parkinson's community with a better understanding of Parkinson's and the treatment options currently available, as well as looking forward to new advances and moving closer to a cure. There were plenary sessions every morning that everyone was invited to attend all together, preceded by hot topic sessions, both of which were quite scientific, but the scientists and researchers really did their best to make their presentations lay-person friendly, so that folks like me could get the general idea of what they were talking about. The rest of the day was comprised of workshops, roundtables, technology talks, and discussions on the most recent and cutting-edge scientific and clinical research, as well as advances in care and quality of life for people living with Parkinson's. There was an exhibit hall with hundreds of posters and exhibitors from around the world, including our own Parkinson Canada booth, where we had the opportunity to network with many people from various parts of the world, even people from Canada, which was really exciting to see some folks there. You could sign up for yoga, dance, boxing, singing, massage, Reiki, meditation, you name it, they had it. In other words, there was something for everyone. For me personally, my most important take-home impression was that this was a meeting of hope. The hope for a cure, and until that time comes, the hope for a better quality of life for those living with Parkinson's. This was also a meeting of inspiration, a meeting where researchers and scientists who work in the labs day in and day out had the opportunity of meeting individuals with Parkinson's. And throughout the week, I often heard them say that having the chance to interact with people living with Parkinson's inspired them to continue their work and never give up. That was a huge overarching message all week from everyone. Never give up. It was also a place where those with Parkinson's and their families met others from around the world who inspired them to power through their disease, knowing they are a part of a global Parkinson family that is working toward a common goal, to end Parkinson's once and for all. Bringing the whole Parkinson's community together at the World Congress accomplishes several things. It allows everyone to listen to high-level scientific sessions, as well as discussions on current work being done to advance science and improve care for those living with Parkinson's. It helps to sensitize researchers to the needs of people living with Parkinson's. They're not just looking at petri dishes and animals in a lab. They had this opportunity to actually meet folks with Parkinson's. So they can see firsthand the challenges that you face every day. It also helps people with Parkinson's to understand the challenges that researchers face, as well as other healthcare professionals, in their effort to find a cure and offer better care. So now I'm going to share some of the things I learned at the Congress. These are not in any particular order and are meant to be overviews of several big picture topics. I can't talk about everything I learned today, but I wanted to touch on a few that I felt were really important. The first topic I want to talk about is the relationship between deep brain stimulation surgery and depression. As many of you know, deep brain stimulation surgery has been available to individuals with Parkinson's for over 30 years. As with any new treatments, there are always things that doctors learn as time goes on. And I think the best way to describe what they have learned about DBS is that the precision of the targets are critical for the patient to receive optimum benefit from the surgery. In other words, the very precise areas in the brain where the symptoms are that are most troublesome to the folks living with Parkinson's. So you may be sitting there thinking, well, duh, of course they have to put the electrodes in the right place. That's not rocket science. What I'm trying to tell you is that researchers and neurosurgeons are refining or fine-tuning the targets in the brains of people with Parkinson's in order to improve the outcomes and reduce the side effects. The pathways in the brain for deep brain stimulation surgery are once again under construction in order to shape the roadway and direct the traffic so that every electrode gets to exactly where it needs to get to and in a timely fashion. As most of you know, there are two basic types of Parkinson's. The first is tremor dominant, which is the type where individuals have involuntary trembling of the limbs, and tremor is often the initial symptom in this case. The other basic type is called akinetic rigid Parkinson's, where the most characteristic symptoms are stiffness of the muscles and lack of movement or slowness, initiating and maintaining movement. Many individuals have all these symptoms, but one or two of the symptoms are more predominant than the others. When it comes to DBS, the circuits for these various motor symptoms are similar but different. So for this reason, careful assessment of the patient is imperative when it comes to placing the electrodes, whereas in the past, the type of Parkinson's wasn't necessarily always taken into consideration. Another thing I learned is that depression can make some patients treatment resistant, which may be one factor why some patients who undergo DBS get better and others do not have such a positive outcome. They are also now looking at multiple targeting networks to get improvement of more than one symptom at a time, which again is something new. So what I'm trying to tell you is that they might be trying to improve some of the motor symptoms, but also looking at improving some of the non-motor symptoms, such as depression, all at the same time. So just as with medications, DBS is targeted to improve tremor, rigidity, stiffness, and slowness. But just to keep in mind also, there is no improvement of balance, cognition, that's thinking clearly, speech, or freezing. So it's very important to know exactly what DBS can improve and what it won't improve before one embarks on looking at DBS surgery. Another thing I learned about DBS is how important the Levodopa challenge is. So for those of you who are wondering what the heck a Levodopa challenge is, it's part of the workup to determine if the patient might be a good candidate for deep brain stimulation surgery. Patients have to stop taking their levodopa, imagine that, stop taking their levodopa or their Cinemet for at least 12 hours before the test so that they are in an off state when they get to the hospital. It's not a very pleasant thing to have to go through, but it's very important. Once at the hospital, then the patients are given their levodopa, so the surgical team can see how long it takes the medication to kick in, as well as how long the medication is effective for. DBS is only as good as the patient's best on state with medication, so it is very important to ensure that patients are getting really good benefit for their medication, regardless of how long that benefit lasts. The benefit lasting is not the important piece, is how much benefit they're actually getting. This test will be able to tell both the patient and the patient's family, as well as the surgeon, how effective the surgery will be. So there's a direct correlation between these things. They are also looking at doing the DBS procedure on younger patients now. And patients over the age of 70 are usually excluded, as brain surgery in old adults can cause problems with cognition. On the other hand, the risk-benefit ratio is also beginning to shift with respect to the age factor, as well as they have seen very disabled patients over the age of 70 have improvement in their quality of life. So once again, it's a moving target. Never say never. I have to stop talking about DBS soon, or I won't get to anything more today. But just a few more really interesting things I learned. There is a hospital in Portland who is now doing DBS using a general anesthetic. In other words, the patients are actually asleep during the procedure, whereas in the past, and still in most of the settings where surgery is done, patients have to be awake throughout the whole 6 to 8 hour procedure. So this is something very new and probably something that will catch on in the rest of the surgical units at some point. They are working on rechargeable batteries, so patients will eventually be able to recharge their own batteries and won't require battery replacements at the hospital, which are usually done on an average of about every 3 years. They are also working on using the internet to do DBS via telemedicine. There is actually a company in China who is taking the lead on this. So you can imagine DBS done on the internet via telemedicine. My goodness, all of this new technology is really mind-boggling, especially for a dinosaur like me. Anyway, it's another new thing. And they are also working on a way that the stimulators will only be able to be used when they are needed, when they need to be, not on a consistent basis as they are now, thus saving some battery time and the need to either recharge or replace batteries. So, the take-home message from all of this is that your brain controls everything, and researchers and surgeons, can control your brain. In other words, DBS is a very powerful therapy. I just want to finish this with one more thought. It is actually widely recognized that the biggest problem with DBS is that patients have unrealistic expectations about what DBS is going to do for them. DBS actually has been shown and researched and proven to be better if patients have also a very positive attitude about its results. If patients have a negative outlook about what the surgery will do for them, they will actually experience more side effects, and one of these poor side effects could be poor fluency of speech. So it's really all about the power of positive thinking in this case. Another thing, researchers feel that there is a big disconnect between the examiner and the patient being considered for DBS. In other words, they realize that it is imperative for doctors to understand what is important to the patient prior to the surgery, and patient expectations must be addressed beforehand. Finally, doctors recognize that there is a great need for support and counseling after the surgery has been done, whereas in the past, patients and family members have basically been left to find themselves help and support after being discharged from the hospital. It's like the doctors have kind of washed their hands of providing support for patients, and now that's really being examined, and they realize the patients and family need ongoing support long after the DBS surgery has been done. Next, there was some information about a new technique referred to as focused ultrasound, I should say, that is being used in neurosurgery, which according to the presenters will give DBS a run for its money. As I'm sure you can imagine, this gained a great deal of attention among the attendees, as the results would be the same as DBS, but there would be no incisions or wires. The idea of focused ultrasound is to produce a brain lesion with focused ultrasound. In order to do this, multiple ultrasound beams from many sites around the head are focused in at a specific target deep within the brain. For one part of the brain that this has been tried on is an area called the thalamus. The energy from each individual ultrasound beam is too low to damage tissue. So in and of itself, each beam is too low to actually damage the tissue. Where the beams converge, in the additive energy destroys a small area of brain tissue. In other words, the lesion occurs only at the site where the beams actually overlap. It has to be targeted to a 1 millimeter spot in order to burn the cells that are causing the problem for the patient. This approach requires similar technical strategies as conventional lesioning procedures to precisely locate the intended brain target, so it may not be quite as easy or straightforward as it sounds. The challenge with this kind of treatment is proper localization. Basically, there's no margin for error when brain lesioning is being done. At this present time, this approach is still a work in progress for Parkinson's. It has been tried on many patients with essential tremor, but it is still a work in progress for people with Parkinson's. But in time, it will answer the problem for individuals with Parkinson's who need surgery but don't want to have anyone basically drilling a hole in their brain. So it's holding a lot of promise at the present time, but is still very much in research mode when it comes to Parkinson's. I attended a special lecture titled Levodopa Over the Past 50 Years, Where We've Come From and Where We Are Going. So the next thing I want to share with you is about levodopa. That's your Cinemet or your Prolopa. And before you all groan and say, "Oh, Sandy, not that topic again," I want to read a direct quote that I wrote down verbatim during a presentation by one of the world's leading movement disorder specialists. So here goes. The introduction of levodopa therapy in 1969 and 1970 changed everything. It revolutionized treatment, it pulled people out of wheelchairs, and it increased longevity. Levodopa will always remain a priority in the treatment of Parkinson's, even if protective therapies emerge one day. So for those of you who are wondering why doctors are still prescribing levodopa, a medication that was developed over 50 years ago, the answer is that we all have levodopa in our systems naturally. Every human being produces levodopa naturally. So, the bottom line is, all doctors are doing with people with Parkinson's is basically replenishing a natural substance that for some reason has become deficient in the brains of people with Parkinson's. Sounds simple, doesn't it? If only that was the case. Because as you all know, it's anything but simple and straightforward. This lecture covered several things, including gaining a better understanding about the barriers to achieving constant brain levels of levodopa, understanding the intricacies of converting levodopa into normal movement, how to become familiar with different responses to levodopa. My biggest take-home message from this lecture is that treatment with levodopa is truly an art, as there are numerous obstacles in the way of achieving optimal treatment. One obstacle is the fact that people with Parkinson's often misinterpret symptoms or describe them ambiguously during their doctor's appointment. Coupled with that is the pressures of modern medicine that forces physicians to maximize efficiency, and hence there is often insufficient time in a busy practice to wade through the complex symptoms. The distinction between the symptoms of Parkinson's as well as medication side effects is a frequent source of confusion, with potential for ineffective or inappropriate treatment. Also, treatable symptoms are not even recognized often as part of Parkinson's. So I'm sure by now you can see where I'm going with this. Your doctor doesn't have a crystal ball, and it is only with your help and for a very short period of time, 2 or 3 times a year, that they can help to try to figure out what's going on. It is very important for you, therefore, to be as knowledgeable as possible about your Parkinson's in general. About your Parkinson's in general, I said, as well as about Parkinson's in particular. So when you do see your doctor, you will be able to have informed communication with him or her in order to get the best treatment available. You may be wondering what all this has to do with levodopa. The answer is everything. Levodopa may be the gold standard of medication therapy for people living with Parkinson's, but the dose, the timing, and the frequency depends not only on what the doctor sees during your brief examination, but also on what you are describing during that brief encounter. So what you say and the accuracy of what you are sharing will have a great deal to do with the outcome of your treatment. I've mentioned to you before that levodopa is absorbed in the small bowel. So things like constipation and erratic absorption really interfere with the medication getting into your bloodstream. The example that they gave was of a patient who takes levodopa every 2 hours. This particular patient is getting good response to the first 2 doses, but the third dose is less beneficial, and the fourth dose is not effective at all. So trying to assess levodopa absorption when it is so erratic is a nightmare, not only for the patient, but for the doctor as well. This is where the new formulation of levodopa, called Duodopa, is sometimes prescribed, as the medication, in this case, goes directly into the small bowel, and absorption is much more consistent. It was also emphasized that levodopa must be taken on an empty stomach, 30 to 60 minutes before a meal, or 2 hours after a meal, in order to get maximum benefit from the medication. But I know you all know that, so I won't go into that any further today. If by chance, however, this is news to you, and you would like more information on this, please give me a call or send us an email. We will be happy to talk to you about this, as you need to get the best bang for your buck out of your medication. So to summarize the levodopa lecture, it was emphasized that research needs to focus on more continuous delivery methods of levodopa, such as Duodopa. Also, doctors need to think outside the box and consider variable delivery of levodopa based on the patient's needs. In other words, your medication, frequency, timing, etc. really needs to be based on when you need the levodopa to be working for you. And what I mean by this is the doctors need to listen to their patients and be prepared to individualize treatment to each patient's unique needs. You, as well, the people with Parkinson's, need to educate yourselves about Parkinson's in general, and again, your Parkinson's in particular, so you can talk effectively to your doctor and communicate exactly what's going on. It was also stressed that new methods to measure motor functions throughout the day need to be developed so that doctors can get a better idea of how your Parkinson's is affecting you each and every day. The next lecture I attended was on depression and anxiety. This session noted that even though Dr. James Parkinson cited observations of patients who were lethargic and sad in his essay on the shaking palsy back in 1817, very little attention was paid to the non-motor symptoms such as depression and anxiety until about 10 or 15 years ago, when the conceptualization of Parkinson's started to change, and things have really changed radically and in a hurry since then. It was also noted that the pre-diagnostic presentation of Parkinson's, that's symptoms that were present before you noticed a tremor, slowness, or stiffness, includes such things as depression, anxiety, constipation, loss of sense of smell, rapid eye movement sleep behavior disorder, that's when you act out your dreams, along with anxiety and depression being the most common of these non-motor symptoms that show up before the motor symptoms. The presenter stated that at least 40% of patients will develop depression at some point on their journey with Parkinson's. And as far as he was concerned, he thinks the average of people with Parkinson's who have some severity of depression at some point is actually closer to 50%. The risk factors for developing depression are actually the same for people living with Parkinson's as well as the general population. That's another fact that I wasn't as aware of as I could have been. It was stressed that apathy is often confused with depression, and that pardon me, these two things can be difficult to tell apart. Apathy is actually a distinct disorder on its own and is what is known as a dopamine responsive problem. I found it interesting to learn that when the dopamine agonists are removed to improve impulse control disorders, in other words, people who are having problems with such things as shopping, gambling, eating too much, etc., that when the agonists such as Mirapex and Replip are removed, apathy always increases. Interesting. Apathy implies disinterest, indifference, or disinclination to engage in usual activities. This does not usually occur until an individual has had Parkinson's for many years, and if the individual is elderly, which today means usually in their 80s or 90s, it may also be an indication, possibly, of an early stage of dementia. It is very significant to note the patients with apathy state they don't feel sad. They've just lost interest in doing things that they used to enjoy. Apathetic people behave as if they no longer care about things, again, that were previously of interest. They may prefer to spend the entire day in their easy chair rather than going out with family. Apathy does not respond to Levodopa or any other of the Parkinson's medications, unfortunately. But again, patients don't feel sad. Depression, on the other hand, is synonymous with feeling blue, feeling unhappy, sad, gloomy, hopeless. People who have depression state that their glass is always half empty rather than half full. Folks with depression can't sleep, they have a loss of appetite, and they sometimes worry obsessively about everything and always expect the worst to happen. The good news is that depression is treatable, but it needs to be recognized. You must communicate honestly with your doctor about how you are feeling. They can't treat what they don't know about. There are several clinical trials looking at new medications to treat depression right now that are showing promise, but the medications that have been shown to help with depression in Parkinson's, such as nortriptyline and Celexa, still work well for many people with Parkinson's who suffer from depression. Currently, there is no study yet for specific anti-anxiety medications, but the good news is that many of the currently used antidepressants also treat anxiety. It was stressed that anxiety is not a psychiatric symptom. It is a universal emotion. Everyone expresses different degrees of anxiety at various times during their life. It's part of our stress response system. There are 4 basic types of anxiety. That is, there is a general anxiety disorder. Those are people who have continuous fear about everything. There is a social type of anxiety, where people don't necessarily feel anxious at home, but definitely experience quite severe anxiety when they are out in public. There is an anxiety disorder that is actually a panic disorder, and that is when individuals experience unprovoked panic attacks on a regular basis. There are also specific types of phobias that are related to things like spiders, snakes, elevators, closed spaces, all of those kinds of things. And those are considered very specific types of anxiety as well. Anxiety actually occurs in over 31% of the general Parkinson's population. So that's a high percentage of people who experience anxiety. It was stressed that there are several things individuals can do to help themselves that don't actually involve taking medication. Cognitive behavior therapy is one example of self-help. Cognitive behavior therapy is a highly structured form of talk therapy, which targets your thoughts and your behaviors. It is skills based on and is good for enhancing your quality of life and giving you more control over you. Increased involvement in meaningful and social activities has been found to be very helpful for anxiety. So getting back to doing old activities that you used to enjoy, modifying your activities that were once important for you, or finding new things you enjoy and getting out and about. Again, all part of self-help. An example of a modified activity. One of the first people that I met with Parkinson's was a lady who used to enjoy downhill skiing. When she was no longer able to ski downhill, she went and changed to cross-country skiing. So she was still able to enjoy skiing. And she was a real outdoors person. She loved being out of doors. When she was no longer able to do cross-country skiing, she went to snowshoes. When she was no longer able to snowshoe, she went for long walks on winter days in safe environments, outdoors. Again, that's an example of modifying an activity. She never gave up what she enjoyed. She just found different ways of doing it. Problem solving for physical limitations as exercise. It's very important that you problem solve for your physical limitations, as exercise is not only beneficial but essential to reduce anxiety as well. Such things as pacing your activities, making appropriate goals with less rigid demands, planning your activities around your off times or your on times. In other words, if you used to go for 30-minute walks, maybe trying walking for 10 minutes a day instead of 30 minutes at a time. 10 minutes 3 times a day works just as well. Also make sure that you follow through with referrals for occupational therapy to see if there are any equipment that might be beneficial for you, or your physiotherapist, so that exercise and rehabilitation activities can be provided. That sort of thing. Make sure that you take advantage of any type of health professional that might be able to help you to continue with your regular activities. It was stressed that relaxation exercises play a big role in managing anxiety. They've been found to be very beneficial for people with Parkinson's and their anxiety. Things such as breathing exercises, progressive muscle relaxation, guided visualization, and a new one on me called worry control. That's when you have thought monitoring, restructuring. That was something I found very interesting. And basically, this is when you catch the negative thought you have and you try to get rid of it and blow it away. That is anytime you say, I can't. You pretend you have a remote control in your hand. You press pause, then press rewind. Think, I can do that. And if I just change this, and then you press play. I thought that kind of worry control using a pretend remote control was a very interesting idea. I'll leave you with 3 thoughts that I loved from this presentation. The first is, no one has a choice of whether or not they're going to have Parkinson's. Everyone does have a choice, however, about how you're going to cope with it. And finally, in order for any techniques to be helpful, They need to be consistently practiced and integrated into your daily life. In other words, for example, don't think for 1 minute that doing your Dancing with Parkinson's once a week, or going to your exercise class once a week, or going to your speech-language pathologist and doing voice training exercises once a week is good enough. Remember what I said. In order for any techniques to be helpful, they need to be consistently practiced and integrated into your daily life. That means these things need to be done each and every day. The session on non-motor symptoms focused on the fact that doctors really need to listen to their patients, as well as to their care partners, as it was stated that the strongest predictor of how well patients will do and what their quality of life will be in the treatment is the treatment and management of their non-motor symptoms. So there is no question that there is a direct correlation between your quality of life diminishing as a result of an increase in your non-motor symptoms, because either your doctor isn't aware of your problems or the fact that your doctor isn't aware of non-motor symptoms, period. Reporting of non-motor symptoms will drive your treatments, so it is essential that patients be allowed to communicate with doctors and for doctors to listen. Only 2% of people living with Parkinson's will not have non-motor symptoms. Basically, everyone with Parkinson's will have some, usually more than one, and sometimes as many as 10 non-motor symptoms. So like it or not, I'm betting that all of you listening to me today have some non-motor symptoms. If any one of you isn't familiar with that term, non-motor symptoms, again, please call me. I'll be happy to tell you what they are and provide you with a great resource that you can read called the Non-Motor Guide. We also have non-motor guides that were written for physicians that can be given to your family doctors, your general neurologists, etc. And for those of you who are fortunate enough to have movement disorder specialists, I'm sure that you get asked about your non-motor symptoms at every appointment. An average of 33 to 70% of non-motor symptoms appear before your motor symptoms. And most patients say their non-motor symptoms are much more problematic than your motor symptoms. Gosh, I realize I'm running out of time. There's so much more I wanted to share. But I just have time to talk about one more topic in depth today, and that is stem cells. What are we doing about stem cell therapy? The bottom line is, what are we trying to achieve? The fact is, stem cell therapy is not, nor will it ever be, a cure. So basically, we need to understand the rationale for using cell-based therapy. The rationale is to try to do the same thing we are currently doing with dopamine therapy. For example, like levodopa without the side effects. In other words, in order to qualify for stem cell therapy, you would first need to be getting a very good response to your dopamine medication. So I'm going to back up the bus for a minute here. Back in the 1980s, a cell-based therapy known as fetal cell replacement was shown to be beneficial on mice and rats who were given Parkinson's using a heroin-like compound called MPTP. It's a very interesting compound, but that's a story for another day. So the reality is, researchers and scientists can actually give mice and rats Parkinson's. Okay, back to fetal cell replacement. So the mice and rats, that's the animal studies, improved. And in the late 1980s, fetal cell transplants were done on humans. One patient improved using this cell treatment over a 3-year period. In the early 1990s, several patients were given fetal tissue transplants, and it was nothing short of a disaster. One might say it was actually catastrophic. At the end of 1 year, most of the patients had developed severe dyskinesias to the point where they were moving so much they were actually frozen. That might sound strange, but think about what happens if you spin a top. You know, those toys that were designed to spin rapidly. I'm sure you've all done one. I'd spun a top at some point. And the motion of that spinning top causes it to remain precisely balanced while it's spinning because of the change of speed. I'm sure you've also all spun a top in your life, so you know when it reaches its peak or top speed, it actually doesn't appear to be moving at all. So that's basically what was going on with these patients. What happened was that the cell transplants worked very well and produced lots of dopamine, just like they were supposed to. The problem was that there was nothing to stop this production, so they just kept going and going and going. So patients developed such severe dyskinesia just as if they had all taken far too much cinnamon. Subjectively, the patients said they definitely felt much worse, not better, and most patients required other brain surgeries, like DBS, to fix this overproduction of dopamine. So the bottom line is the graft-induced dyskinesias couldn't be treated like the medication-induced dyskinesia, because medication can be reduced, but a graft is a graft. It's in place permanently. There is some good news, however. In spite of that catastrophic outcome of the fetal tissue transplants for so many patients, remember I told you that one patient improved after receiving a fetal cell transplant? What I didn't tell you was that that patient went from being off 2/3 of the time to being on all day. That patient continued to do very well for many years and passed away in 2013. At that time, the patient had given their brain to research, so an autopsy was done on that patient's brain. The postmortem examination, remember, we're talking about a 20-year time span here, excuse me, showed that the transplant graft was still working very well. And it turned out that that patient had actually not needed to take any medication for all those years. So what am I trying to tell you? I'm trying to tell you that there is definite evidence, proof, to show that cell transplantation can work once all the kinks have been worked out. What the researchers are working on now is developing new clinical trials using the following: the right patients, a new and improved way of introducing stem cell transplants into the brain, ensuring that the grafts are placed in exactly the right areas of the brain, and ensuring that the dopamine cells they are planning to use are from the actual substantia nigra, and they're going to be both used in a safe and effective way. Because what they've learned from previous cell transplants was that they didn't choose the right patients. They didn't choose the right kind of stem cells. The clinical trial design had several flaws, and they didn't take into account something called immunosuppression, which is developing a drug to ensure that the body does not reject an organ, or in this case, that it does not reject the stem cell transplant graft. The plan right now is to start clinical trials again in 2018 or 2019. And just to put this into perspective for you, I have mentioned in previous chats the clinical trials are extremely costly, and it takes a long time to prove that new treatments are both safe and effective. In this case, it will cost approximately $2.6 million to just produce a few stem cells. You may have read that there are stem cell trials currently underway in Melbourne, Australia, but the consensus of opinion at the Congress of the researchers there is that these trials are under-researched and that the preclinical evidence is lacking. In other words, they didn't do all those steps I've just talked to you about, which is what they said was a very big concern for them. I have never attended a Parkinson presentation where the presenters spoke so vehemently about promises that are being made by unscrupulous companies in this world today who are saying that they can cure Parkinson's using stem cells. The statement was, beware of any new stem cell treatment, especially if you have to pay for it. You are just throwing your money down the toilet because we are not there yet. When it works very well. But sham clinical trials that are not scientifically approved could sink the entire stem cell treatment plan for the future. And that is not a place any of us wants to be in. So the best way to ensure that this doesn't happen is to not support any company offering stem cells at the current time, as that will force them to go out of business, and the scientists and researchers will then be able to carry on with their very hard work to bring the really good scientific and evidence-based clinical trials up in, again, out for your that you can participate in 2018 or 2019. As hard as it may seem, wait until the researchers have this scientifically based evidence and approval. That day is coming. 2018 is not that far away, and we need to ensure that we get it right this time. One of the problems, of course, is that there are no stem cells in the brain, so they have to come from other parts of the body. Embryonic stem cells can be made to become dopamine cells with difficulty because they're like kindergarten kids. They're hard to control and made to behave in the way you want them to. On top of that, there has been and still is a great deal of controversy about using embryos, even though the only ones that have been used are those that are being discarded or thrown away for a variety of reasons. So where are the researchers getting stem cells from? Stem cells have been taken from both blood and bones, but they proved to be quite unsatisfactory routes. At the present time, stem cells taken from skin look like the most promising source, but that is by no means the end of the story. I learned another new thing about stem cells. The presenter started to talk about Ips cells, and to be honest, at that moment, I had no idea what he was talking about. Fortunately, he went on to explain that Ips cells are induced pluripotent stem cells, and the term pluripotent means that stem cells can divide a lot, and they actually can become any cell. In other words, scientists can reprogram them, teach them to become dopamine cells, which then they can put back into the brain of the same patient. The question is, how stable are these reprogrammed cells? Pardon me. And are they going, and are they going to last for the next 30 years? We know that these types of cells have worked in the heart, but they can also, we need them to be sure that they can also be treated with drugs so that they will show a lot of promise. But again, we need to ensure that these clinical trials are safe. So they may be safe, but at the present time, they've been shown to be ineffective so far for people with Parkinson's. So again, we need to be very careful and cautious how we go forward with stem cell treatment. I know that's not what you wanted to hear, but you deserve to know the truth. Please don't waste your money on promises from companies who promise that they can cure you with their current stem cell treatment. Well, I've run out of time for today. I've only touched on some of the highlights and hopes from the World Parkinson Congress. However, just one lasting thought. The tenacity, heart, and courage of people living with Parkinson's and care partners who face their daily challenges of living with Parkinson's with both grit and grace, coupled with the dedication and passion of the researchers, clinicians, scientists, and all healthcare professionals in attendance at this Congress, left me feeling inspired and hopeful as that there are huge steps being made toward improving the quality of the lives of people with Parkinson's, one magnificent step at a time. In the meantime, live each and every day to the fullest. Thanks for listening today. Take care. See you in December. And bye for now.
The leader has turned lecture off and your line has been unmuted.